Dale, thank you so much for that introduction. And it's clearly an honor and a pleasure for me to be here tonight. I feel I've come to Prescott to be on a Broadway stage, but no cats tonight. So again, I have the honor of being the first speaker. We are going to try to time everything so we get done, and we're not going to try to make this very technical. We want to make sure that everybody in the audience comes away with understanding what it is that we're trying to achieve when we do patient blood management. So I was given the honor of presenting to you this talk on patient blood management, why, what, and now. And generally speaking, we start usually by having disclosures. You can see these are not conflict of interest. I feel very strongly that we as physicians need to work with the pharmaceutical, device, and biologic companies so we get the right things done by those in the industry for the patients that we're taking care of. So I see this as us directing them. I'll start with why patient blood management and talk to you a little bit about the forces within healthcare that have actually ended up recognizing that there was an unmet medical need. And us as physicians, clinicians, nurses, and everyone else that's involved in the care of the patient needed to approach this in a sort of a problem-solving way. Now, I will tell you that there is this equation in terms of value, which is quality over price. But that equation can be manipulated, as you could see in the denominator. I'm not very good at math, but I know that if the denominator goes down, then the value goes up, meaning you can have the same quality, but if the price goes down, the value goes up. In fact, with patient blood management, quality goes up, price goes down, and value goes up, because we have been engulfed in our minds in medicine with transfusion. And transfusion is a therapy. We need to identify the disease. And the problem in the past is that we look at healthcare both from the clinical eye and the administrative eye. In the clinical eye, I will tell you that transfusions have been associated with very poor outcome. Survival of patients transfused versus non-transfused is worse. And well-being, the feeling of recovery, if you will, is very short-lived and also a very poor measure for patients transfused versus non-transfused. On the administrative side, you see that the cost of transfusion, which was unknown until 2000, is very high for hospitals. But they see this as just doing business. It's when you start looking at this, you could see that there's an enormous opportunity, cost-wise, where you can repurpose dollars from an ineffective, unsafe possible procedure without much benefit to patients, as I showed you on the clinical side, to areas where you can make a very positive outcome. Efficacy is a measure of benefit, and the measure of benefit has really not been addressed when it comes to transfusion medicine. We have not identified that particular patient who will identify from a transfusion, except for those who are hemorrhaging. And our our regulatory agencies spend enormous amount on making a transfusion medicine or blood safe in the United States. We spend inordinate amount of money, but we spend zero on prevention of transfusion. So you could see that they're out of step. And the current paradigm of healthcare, meaning, again, high cost, low quality, with very low value, has to change. So transfusion medicine starts with the treatment and not the patient. If I was talking to you tonight about diabetes, my whole topic would revolve around insulin. Those of you who know the disease, you know it's much more complex than just insulin, and insulin is only one of the therapeutic intervention for diabetes. There's many things that we do, including diet, weight loss, exercise. So start thinking in terms of what's the disease. And the risk of the disease, actually the disease is anemia, and anemia has an independent risk factor, and treating anemia with transfusion compounds the problem, because transfusion, as I already showed you in the previous slide, are associated with worse outcome. And the treatment itself is not scientific, it's behavioral. So most patients who get transfused in these United States, it's because they're in an institution that has a level of behavior. There is no science behind that. Again, I already mentioned, we're looking at the target population. We have lots of expensive trials out there that keep giving us the same answer over and over again, but the behavior has not changed of clinicians over the years, but we're now seeing that with patient blood management. And we have to get away from this upside-down thinking, which is the therapy before we address the disease. So transfusion as a whole, and when we talk about transfusion medicine, not free from risk, hurt, or injury, includes disease transmission, immune modulation, hemolytic and allergic transfusion reactions, acute lung injury, ALI, transfusion-associated circulatory overload, or TACO, and many others. It is not dependable therapy. Allogeneic transfusion, banked blood, cannot be depended upon to achieve the desired outcome. Not every patient who receives it, and we know very few, improve on their health. So we're in a grid, if you will, of healthcare, trying to look for something that has low cost and has high quality and efficacy. And I will demonstrate to you that we've found one area, and that's patient blood management. So the difference between the two, meaning transfusion medicine or blood management, which is inventory, it's getting blood ready for those possible recipient, versus patient blood management, is actually very different. One is product-centered, and patient blood management is patient-centric. And again, on the list you could see preventative. It's, I mentioned, patient-centric. We can treat patients preoperatively. It is transdisciplinary, meaning it involves everyone in terms of the care of the patient. We want to look at holistic approach to patients. Multi-professional, it's not just doctors. It's everyone in the hospital, all the way from the C-suite, we call it, or the chief executive officers, all the way down to those people in the front line caring for patients, moving patients, preparing things for patients. Everybody has to be on board. It's multimodality. We collect things. This is integrated care. This is what we're looking for in healthcare today, and we can provide it with patient blood management. And ultimately, as you'll see, it's outcome focused, meaning that if we can show improvement in outcome, the quality side, we're not really providing what we need to the community. So this is 5 drivers, I'm going to go through them, that have changed what we've done in the past to now bring patient blood management for the forefront. And on the top right of the slide, what you're seeing actually is something called the 4-leaf clover, which is our definition, if you will, of patient blood management by the Society for the Advancement of Blood Management. So we'll talk a little bit about supply issue, and now today we talk about it as not being a major issue, but the issue is for those who supply us is now become an issue because blood use has gone down. Talk about cost, talk about inherent risk of transfusion, some of the adverse outcome, and what I'm going to do is present each one with data, and then efficacy and effectiveness, or the lack thereof, as we advance. So we'll start with a supply issue. Again, the change in demand can adversely affect blood collection agencies. It's very important to understand that this may be good for patients in terms of reducing the amount of blood transfused in the United States. Again, only transfusing those where there's clinical indication, where patients for whom blood is an option receive it. For patients for blood is not an option, there are other modalities that we could use. Again, less transfusion when it's not necessary, meaning we're not providing patients with risk anymore when there's no benefit. The changes in demand have large implications. Changes in demand have high implications. In the United States, we collect approximately 3 million fewer donations than we did in 2010, and that number is going down. U.S. leads the world in the number of units transfused per population, so we match it. So why are we transfusing so much in the U.S.? Because it's available. And you could see that over the years, you could see that there was a rise in transfusion because there's plenty blood available. Up to 50 units of red cells per 1,000 population. We now can compare per 1,000 population from one country to another. And you could see that over the years, after the HIV epidemic and hepatitis C, there's been a decrement and the inclusion of patient blood management. There's been a significant reduction. You could see that there's significant reduction in use. And right now, we're supposing that we'll reach at some point 17, less than half per 1,000. Why? Because in Western Australia, they're already down to 19 per 1,000. And Western Australia has the same medicine and diseases. They're different is that they have kangaroos. We don't have them. But the fact of the matter is, there's no different disease. And if they can get their transfusion rate down below 20 per 1,000, so can we. So you could see how that impacts on the blood industry. This shows you different countries. White is the actual blood collection. Red is the actual blood transfused. And what I'm really showing you is that there's very little difference between the two. Now why? What's driving what? Is it the availability of blood that's driving the transfusion rate, or is the transfusion rate driving the availability? We don't know the answer, but look how tightly they are together, and any change in these will have some ramification, and we're seeing it not just in the US, but we're also seeing it in the world. Again, the Department of Health in 2013 was concerned in terms of the decline in demand for blood, and blood banks laying off staff, reducing size, holding I don't know why it's moving automatically, holding fewer blood drives, reasons for fewer transfusions. There's also the modern surgical technique, which have reduced transfusion because less blood loss. Patients reuse their own blood, something we introduced with blood conservation, and they're all result in a significant cost saving through patient blood management strategies. Well, what is the concern? Well, I could tell you right now that the oil industry is going through the same thing, reduction of use. But everybody's doing the same thing in their comfort zone. We have to change the way we manage, or the way blood is managed and delivered in the United States, to be able to survive, for those centers to survive this change. This change is not going to go away. It is a reality. And trying to subsidize that, whether it be oil prices for the oil company or blood prices for the blood centers, is not going to result in what we need. We may need to deliver blood to our hospital with Uber and not with big trucks. FedEx may be the place that we do it. Think of it. We've got to change what we're doing, and this is the recommendations that we gave to the blood industry while we're improving patient outcome by reduction of waste and reduction of harm. Now we go to cost. So, as you know, I already mentioned to you, we spend enormous amount of money in this country to make blood safe. I don't give antibiotics to your patient because they're safe. I don't help the surgeon take out the appendix because it's safe. I give a medication because the benefit outweighs the risk for that particular condition. But we insist on making blood safe, which never will be completely safe. But as we do that, we add more and more tests because it's a biologic system and it's at risk of entering another biologic agent entering at any time. Zika today, SARS yesterday, West Nile virus, HIV, hepatitis C, it will never stop. But each time that we need to identify these agents, there's a test. And as you all know, some of you have engaged in healthcare, know that tests are not for free. And each time we do and add one, it raises the cost, which goes to the consumer. And you could see that no matter where you look, there's an annual incremental increase in cost. In 2000, we asked the NIH, that's the next slide. In 2000, we asked the NIH, how much does it cost to transfusing about? Not to buy, to transfuse. And the answer we got is we don't know. How could we don't know? Well, we don't. I said, okay, we'll embark. It took us 7 years and close to $1 million to do this trial. This is what's called activity-based costing. Every moment that your attention is to that unit of blood, from the time it hits the hospital door to the time it gets completed, transfused to the patient, is shown in the slide. So you could see there's 2 hospitals in the United States, 2 hospitals in Europe. So far, you see the yellow is the cost of buying blood from the blood center. Not a lot of difference in Europe and US. The green represents the cost of transfusing a single unit of red cells to a surgical patient. Again, you could see that there's some differences, but it's a lot more than what it is to buy a unit of blood. It's between 3.5 and 4.5 times. An average unit of blood in the United States costs $250. I'm sure it's not too late in the evening for you to make the math in terms of what it costs to transfuse a patient. And the care of a transfused patient is also much more expensive. So we did all these calculations and published it and got no feedback. Some hospitals say, we can't believe it's that high. My response is, I can give you today a 25% discount. It's still going to be very, very expensive. And this gets published in the prominent medical journals like the Wall Street Journal, where it says up here is blood, saving blood, dollars and lives. It appeared in a similar article in Nature, and that was titled, Save Blood, Save Lives. Complete antithesis to what the Red Cross says, which is give blood, save lives. We are turning the corner. We recognize that by giving blood, not everybody survives. That's not everybody doesn't get a complication. We recognize that, and I think we're moving in the right direction. What I want to do is, if you could read it in the back, maybe this is like an eye exam for you, but reducing blood usage by 30% could result in repurposing of 12 million nursing hours, annual reduction of 200,000 wound complications, and 8 million fewer patient days in hospitals, and as many as 50,000 lives could be saved. Now, it sounds very dramatic, but if we're not going to change what we're doing, we're still going to be stuck in what could be versus what is and can be. So now we move to inherent transfusion risk. Now, so far I'm trying to be non-technical, but let me walk you through this very quickly. I'm not going to talk much about this slide. How's that? Basically, people are aware, and we tell patients that blood is safe because the risk of HIV is low, the risk of hepatitis C is low, not as low as hepatitis B. So all these transmitted infections may not be so risky anymore. Well, that's true, but I also showed you that every year we got a new visitor into the blood system. So the fact of the matter is, this is not a big concern, and I will agree that it's not a big concern. It is the non-infectious complications that are the concern. Blood is an organ, and every time a patient receives blood from the blood bank, which is another person's blood, it is a transplant. And the immune effects that it causes, we call it immune modulation, occur with every unit of blood. That risk is there. And all of the complications that are listed on this particular slide all relate to the immune system's response to that particular unit of blood that is being transfused. Now keep in mind, many patients receive more than one. It's an additive risk. It's not a sound barrier. You get one, the rest are free. No, each one has it. Now, some of you may have probably have heard of personalized medicine, where we actually take your DNA, which we could do with a little swab, we send it to the lab, and then we match your genome, if you will, with the ability to metabolize drugs. Some of you metabolize, say, aspirin quickly, some of you slowly, some of you normally. But once I have that information, I could give you a different medication that will do the same, but you'll be metabolizing it well. Here's personalized medicine issue. These are women who were admitted to a United Kingdom hospital for delivery of the babies and end up with postpartum hemorrhage. They received transfusions. But the day before they had the hemorrhage, they were typing cross, and they were looking for Y chromosomes. Last we heard, female gender does not have Y chromosome, it's XX. And you could see the blots here showed the same thing. It's all X chromosome, no Y chromosome. But 1 day, 2 day, 3 day, 2 weeks, 6 months, 1 year, 10 years later, after they got transfused, you could see that there's plenty of Y chromosome in them. And it's alive for up to 10 years, which is the last time we measured. This is called what we call chimera. Now you've got 2 DNAs. You've got yours and you got your neighbor's. So we know that, again, blood transfusions significantly affect recipient immune system, higher rates of cancer recurrence and postoperative infections. My colleagues will argue these are associations, but why are we arguing? We can do something about it. We could treat the underlying condition, not just give therapy. Animal and human data, transfusion immune modulation is associated with infusion of allogeneic leukocytes. It is the white cells that are doing it. Supernatants from stored platelets concentrates also involved in immune modulation. Appropriate transfusion practices could improve transfusion outcome and reduce unnecessary immune modulation. How about appropriate management of the underlying disease? So that moves us now to what we call adverse events. And there's plenty. So now these are studies evaluating the impact of blood transfusion on mortality, which is death after cardiac operation. Now, I'm just giving this as an example. I could have put hip operation, I could have put knee operations, I could have put GYN operations, or any of the likes. And these are different publications from different years, and again, all a conglomerate. But you could see that, again, RBC transfusion predicted early mortality. Cotavalli et al., transfusion significantly associated with 30-day and 1-year mortality, meaning those patients did worse. My colleagues will say, well, wait a minute. Those who were transfused were sicker, therefore they didn't do so well. Well, maybe they were, but if transfusion is going to work, don't you want that to be the same as the non-transfused? Or maybe the data that we have doesn't show that it has any difference in terms of the underlying condition, because we have that from variability of transfusion data. Another one showing a transfusion had a 70% increased risk of long-term mortality. A transfusion had higher risk-adjusted odds of early and late mortality. And then you have, again, transfusion 1 or 2 units of RBC had 16 or higher odds of long-term mortality versus no transfusion. Again, this is in spine and joint surgery, so just to give you the idea that, as a doctor up here, you can trust me. I did tell you I could show you other surgeries that can be done, and we can get the list, but we don't have time all night to go through that. But the literature is replete with these studies. And each time a single study comes up that refutes this, everybody jumps up and says, you see, you're wrong. But how can 10,000 study could be wrong when one study is refuting them? They can't. So again, there are arguments back and forth, but they're not valid. So that brings us now to the efficacy. Does it work? Has anyone tested this particular product, if you will, or a biologic that we call blood? Has it been tested in terms of its efficacy? So you could see these are authors that tells you the first author in some of these studies that have been performed. And again, whether these are randomized controlled trials or observational trials, it tells you what kind of study was done. And then the number of patients. And again, you could see it's a fairly robust number of patients that were done. And then looking at positive outcome, meaning that transfusion in these studies demonstrated improved patient outcome. Was the health of those patients improved with transfusion? Well, let's see here. Negative, 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 negative. Here was a little fluke in the trial. Negative, negative. Oh, positive. Well, this trial showed positive. It showed positive for patients who have very low blood count, but actually showed positive for mortality in those who had a higher hemoglobin or blood count. So again, I'm showing you for balance, but there are some. But again, you could see where the overwhelming results lie. This is another one. These, again, looking at a similar structure. These are the authors, looking at the different population of patients, looking at the numbers. These are smaller numbers. And again, looking at the transfusions in unit, looking at when they were transfused, and then looking at the physiologic impact of what transfusion is supposed to do, and that is including hemoglobin that will transport oxygen. So if you give the hemoglobin, you'd expect the oxygen to improve in terms of its delivery, and yet ultimately the delivery is for the use of oxygen by those tissues. So VO2, which you see again around the red lines, is what we're looking for. And utilization of oxygen, even though there's some increase by some studies, was not improved. In 20 studies, transfusion was observed to increase DO2, transport of oxygen. In 15 studies, no increase in utilization of oxygen. So you can improve the delivery, but you're not improving the ultimate goal, which is utilization. And only in 3 studies there was a mild increase. Now you ask the question, why? What's circulating in your vessels as you sit here tonight, and hopefully you're not angry about because it's an election year, but what's circulating in your vessels are cells that look more like these. That's the normal red cell. If you donate blood and it goes to the blood bank, it sits there refrigerated for up to 42 days. The average transfusion of a unit of red cells is around 20 days in the United States. So, you're taking blood from somebody who's been using it, used blood, storing it for a while, and then giving it to a patient, expecting it to work well. Physiologic, chemical, and you could see structural changes occur. The blood is not the same. It is not the same. So keep in mind it's used and old, and it's not what you can produce. And the whole crux, if you will, of our management patients in terms of red cells with patient blood management is to be able to use your own factory. Everyone here is making red cells as we speak. And we can improve on that and get you to where you need to be with red cells that confer no risk, only benefit, and they're yours. Which brings us to what is patient blood management. So I was asked about the definition of patient blood management, and there are some definitions out there which we may or may not agree with, but we're all looking for something at the end of the day that's going to work for us. So I really don't care which definition you use. I do favor this definition because it's from the Society for the Advancement of Blood Management, and you could see what it says. It says a timely application. What timely application means, it means we plan. We need to know when to do something to make it timely. We're not waiting for something to happen. We're planning to have something done. So it's the timely application of evidence-based medical and surgical concepts that are designed to manage anemia. Now we're talking about a disease. Optimize hemostasis. Now we're talking about a condition. And minimize blood loss in order to improve patient outcome. I didn't see the word transfusion here. Did anybody? It may be part of what we do, but it's not blood product focused. It's a multi-professional, multidisciplinary, a team approach to the patient in a very logical way, identifying the disease or condition and then treating it appropriately. I already showed you this, but now I've expanded it. You could see we're looking at condition, another condition, and now what we're looking for is what our government is telling us is required, and I think they're right, is something called patient-centered decision-making. It doesn't mean that the patient is going to be making medical decisions. It's incorporating the patient into what is important for them. As a physician, what I've known from the literature that's important in outcome may not be at all what my patient needs as an outcome. They may not want to live longer. They may want to have a high quality of life, or they may be willing to give up some quality of life to live longer. I'm using extreme examples, but the fact of the matter is anything in between, whether it's surgical outcome, medical outcome, we need to know what the patient's expectations are and combine them with the plan. So again, this shows the one part of it, which is the blood conservation or interdisciplinary blood conservation modalities. And a lot of these, and behind each one of these, there's multiple things that we could do. Still, the word transfusion is not there. Here, we do have transfusion as a possibility if it's an acute anemia in patients who, again, blood is an option. But we have everything else for everyone else there, which is not transfusion. They take the back row. The front row is identifying what kind of anemia and what's the proper medication to treat it. I already talked a little bit about patient-centered approach, and talking about coagulation is important because, again, many of us don't understand it well. Many clinicians get confused with it in terms of what to do. It's unclear, but we are getting better at educating the medical community about this fantastic symphony of events which is called coagulation. You cut your finger, you bleed. You clot is the first step. Clotting is the first step of healing. You could see how beautiful that is. And now when we explain that to our colleagues, I think we're getting much more traction. Has this been implemented? Well, yes. This is from Johns Hopkins. I know you all know it's in Baltimore. And risk-adjusted clinical outcomes in patients enrolled in a bloodless program. What they're showing is transfusion as the only therapy versus identifying the anemia and treating these patients. And it's about a 1-to-3, 1-to-4 ratio of adjusted cohorts, meaning two groups of patients, bloodless versus those who transfused. I'm not going to go through the writing. I think it looks better on this slide. White is those patients who were on protocol. They received anything but a transfusion, meaning they're not a kitchen sink, a protocol therapy for their anemia. The red were only offered transfusion, which is still very common in U.S. hospitals. You could see the different outcomes. You could see less, again, mortality. You could see that there is, again, less infection, less clotting, not good clotting, bad clotting. You could see all-cause morbidity, all-cause morbid outcomes and death. You could see, again, there's a significant, some of them are not, but significant overall difference between the two. It's very difficult to argue with that because, again, if you can get better outcome at lower cost by directing the right therapy for the right disease, the right time, it's a win-win. Now, what about transfusion and the complications like febrile reactions? Some of you are aware that some people who get transfused will develop a fever. That's only one of the many complications which are immediate with transfusion. Here's a hospital in Maine, and you could see they started the patient blood management program. They had a 60% reduction in blood use over the time that they were instituted that, and a 67% reduction in transfusion reactions. So those who are going to argue, well, morbidity and mortality confounded. Let's look at this. This is a very simple way of looking at this, and yes, you can reduce it. Again, improving the value of what we do. Patient blood management is not a U.S. commodity. The world around us has woken up to patient blood management, and some are moving at much faster speed than we are in the United States. This is our colleague from Valencia in Spain, or Catalan. I think they're trying to secede from Spain, right? It's like the Canadians. But anyway, you could see Manuel Munoz, an expert in iron and iron metabolism and iron use. And again, they talked about patient blood management, orthopedic surgery. And to quote this group, benefits of PBM programs both for the patient and the healthcare system appear indisputable, but they are not easy to implement as several obstacles need to be overcome. And you're going to hear from Dr. Chapa a little bit about that. Others, even a country like Switzerland, which I'm sure you all know only does watches and banks, but here again, they're expanding. All right, they're expanding their repertoire into patient blood management, orthopedic surgery. And what they're showing again, that orthopedic operations and in patients with blood management have a significant reduction in transfusion. They also demonstrate reduction in complications. Win-win? I say it is. Here's another one. This is a small study from Duke, you all know, in North Carolina. They looked at patients for whom blood is not an option, and there was no significant difference in total cost for those patients who were witnesses and controls. No difference in ICU length of stay, total length of stay between the two groups. So, again, directing the therapy to the underlying condition versus just using transfusion. You could see this one showed no difference, but again, they did show that the hemoglobin, meaning the treatment for anemia in patients for whom transfusion is not an option, had better results in the bullet below that yellow bullet that I have up here than a transfused group, which you think would not happen. This is cost effectiveness of patient blood management methods in elective orthopedic surgery. It's again, I could tell you that although there's some shortcomings in the trial, the same song is there. Now, if we can reduce the expense for hospital, can we repurpose those dollars? Or maybe we can actually now get into the game that our government and the payers are going to be in when reducing our payment, if you will, so that we need to address it in every corner of an institution that we can. This is from Parkland Memorial, a well-known Houston, from the Medical Mile in Houston Hospital, in Dallas, Texas. And you could see again that they have implemented this, and what they did is they translated into a dollar amount. So $3 million over 4 years for the U.S. United States of America healthcare costs is not a drop in the bucket. It's vapor, because we measure it in trillions of dollars, right? Now, the fact is, for an institution, though, any hospital, this is an enormous savings. And guess what? It's not just the saving of the dollars, because I showed you there's also reduction in complications, which are costly, and reduction in length of stay, which is costly, and improved patient outcome. Patients are satisfied. Again, showing results in terms of the one endpoint, which is transfusion. These, again, a similar structure. This is the authors and the type of study that was done. And for each one of them, they're demonstrating a significant reduction of use of blood when you, again, have proper goal-directed therapy addressing the underlying disease, and then the right therapy. Again, this just was published. It's still in electronic form. This is patient blood management is associated with a substantial reduction in red blood cell utilization and safe for patients' outcome. So this is a before and after study that was done actually in Germany, in Frankfurt, Germany. There were more than 129,000 patients. It was a standardized transfusion practice, and they used blood conservation and anemia management, and there were no safety concern or signal. So this is a very large trial, and again, showing that not only is this effective, but it's safe. So, where are we now? If I haven't convinced you, which is not my intention, it's just to think about what we're doing and where we need to go. Things don't change overnight, and they don't change overnight in healthcare. It's a conservative group, and you want it conservative, because if tomorrow your surgeon decided to do the appendix from a different approach, you don't want that. You want him to do what works. But when we have something that doesn't work, we need to examine it, and we have decades behind us that transfusion medicine is not the answer for the general population. Patient blood management is. So if I can make you think that way, we can now go to where we are today. So the World Health Assembly, which oversees the WHO, the World Health Organization, in 2007 in September, they initiated what's called the WHA 6312 resolution. And it talks about the availability, safety, and the quality of blood products. And what they did is, in 2010, they introduced into 6312 patient blood management. Why? Because the WHO is not concerned with the US population, they're concerned with the world population. And if any of you visit sub-Saharan Africa, take Chad for an example. I know some of you think in Florida, but this is not the same Chad. Chad has no system for delivery of blood. And if you're going to get blood, you have probably between 25 and 40% chance of developing HIV and hepatitis C. Blood is not an option there. Patient blood management is. So you could see why this is taking a global approach. And in 2012, our U.S. Department of Health and Human Services adopted Resolution 6312, again recommending patient blood management. But since 2012, we've seen talk, but no walk. But we're getting back to them. And we insist that we relook at this because the time has come. And it is no longer just a quality issue. It's no longer a value issue. It is no longer a cost issue. Because when you look at the National Patient Safety Foundation focuses on patient blood management, they got a little wrong focus. But the fact of the matter is, it's gone now to the level of being a patient safety concern, not patient blood management. The current approach to transfusion medicine. And you could see new educational programs that address appropriate use of blood products in medical care. Well, that's where the safety issue lies. But what they should look at is how much safety we can inject into the system by moving to patient blood management. We already said that the Europeans are ahead of us in many ways. This is the British Journal of Anesthesia. This is an editorial by our colleagues. Patient blood management is a win-win, a wake-up call. Call for action in Europe. Actually, in Italy now, the Ministry of Health has mandated patient blood management programs. The Society for the Advancement of Blood Management has clinical standards for implementing these programs. You're already ahead of the game here. Way ahead of the game. And they have standards for quality, standards guide for quality measures that is adjoining that. So you already have an established program, but can we improve on it? Probably when looking at this. But this is from the eye of the clinician. Now, just like unfortunately, the blood industry, as it's contracting its business, is now saying, you know what, we're going to get into patient blood management. We are a welcoming group. And if that's what's going to drive patient blood management, let it be. We're going to guide them. But they also have standards, but they're laboratory standards. 1.1, 0.0, 0.3, they've got all these things that they do in the laboratory. They're not as clinical as what I showed you with the Society for the Advancement of Blood Management, but we welcome anyone. But they can't be, again, a jack of all trade and a master of none. And they are a blood, again, they're an organization, a trade organization that represents blood bankers. So blood management or patient blood management are not the same. But if that's what they want to do, as I already mentioned, we welcome them. In Australia, the National Blood Authority has, these are 5 modules. This is a little old slide because there's a 6th, which is the last module. They've abandoned guidelines for transfusion. They now replace them with guidelines for patient blood management. They're very robust. They can't be used at the bedside. But what they've done is collected all of the positive data on everything that we do in patient blood management, put them into these different chapters for different patient population, and have made the case for the National Blood Authority to now, again, adopt patient blood management nationally. I know it's confusing. We don't know it's a continent or a nation, Australia, but whatever it is, that whole place is now patient blood management. As I round up, Transfusion medicine, I mentioned to you, is product-centered. Patient blood management is patient-centered. What we've done is we're supposed to review our transfusion practices in the hospital. So what we do is we ask, was the transfusion appropriate? And if we say it's not, we send a letter to the clinician telling him it was inappropriate. But the damage has been done. It's not what we need to ask. What we need to ask is, what was the transfusion avoidable? And I submit to you that it is with patient blood management. And with that, we are also treating the patient's disease. So as we summarize this portion of the discussion, we can reduce transfusion by up to 95%. On the bottom of the slides are all of the references, that is the data that supports what I'm saying to you. Mortality by up to 68% reduction. Length of stay, at least by a third. Again, reoperation, especially in cardiac surgery, which is associated with worse outcome, 43% reduction. Readmission to hospitals, which again are a concern for every institution in the United States, and also that's not good medicine, 43% reduction. Complications, reduction of composite morbidity, meaning all complications, as well as infection rate, as high as 80% reduction. And lastly, again, you could see costs can be reduced by as up to almost a quarter. Now, there's many data out there that I'm not showing you that may actually refute some of this in terms of making the savings even bigger. As we're getting more and more information, I think we're starting to understand how the impact of patient blood management has been so positive, and it's moving as a wave now across the United States, and I've also showed you it's moving across Europe. It's now woken the sleeping giant or the sleeping dragon, which is China. We're spending more and more time, Dr. Tibby and myself, in that side of the hemisphere because they are thirsty for doing the right thing for their patient population, which are counted in billions, not in millions. So with that, I thank you.